The operating theater is designed to be a controlled environment, but the moment an induction agent enters the bloodstream, that control can evaporate in seconds. Perioperative anaphylaxis is a systemic hypersensitivity reaction that destabilizes a patient's cardiovascular and respiratory systems with catastrophic speed, occurring while they lie fully anesthetized on the table. Historical estimates suggested these crises were rare, roughly 1 in 20,000 procedures. But modern, high-fidelity data from the UK's 6th National Audit Project paints a different picture. Accounting for reporting delays and misclassified data, the true incidence approaches 1 in 7,000 procedures. The morbidity of these events is severe. More than half of all patients who experience perioperative anaphylaxis require critical care admission, and the mortality rate stubbornly persists around 4%. The mathematics dictate that any active anesthesia provider will inevitably face this invisible threat. Preparing for it is a mandatory clinical requirement. To understand how to reverse this collapse, we have to look at the primary cellular effectors of the crisis, the mast cell and the basophil. When these cells undergo degranulation, they eject a massive systemic payload of potent inflammatory mediators, specifically histamine, tryptase, and prostaglandins, directly into the surrounding tissues and bloodstream. The classic IgE-mediated pathway accounts for 60% of perioperative cases. It requires an initial sensitization phase from prior allergen exposure to produce specific IgE antibodies. Later, when a target allergen cross-links these antibodies on the mast cell surface, it triggers massive degranulation. But an entirely different mechanism exists. Non-IgE-mediated reactions, which older literature referred to as anaphylactoid reactions, do not require specific antibodies at all. Focusing on the mast cell surface, we find the MRGPRX2 receptor. Several common perioperative drugs bind directly here, bypassing the IgE pathway entirely. This direct non-immune activation means a patient can suffer severe cardiovascular collapse upon their very first exposure to drugs like rocuronium. Environmental cross-reactivity creates a hidden web of sensitization. The chemical epitopes in neuromuscular blocking agents are ubiquitous in everyday products, like common cosmetics and household detergents, and the cough suppressant Volcadine. Patients build immunity to their toothpaste and react to their anesthesia. Because severe reactions can erupt without clinical warning or allergy history, the provider must treat every drug induction as a potential anaphylactic trigger. The specific drugs responsible for these events are not static. Over the past decade, the epidemiological profile of culprit agents has shifted significantly. While neuromuscular blocking agents were historically the leading cause, antibiotics, particularly teicoplanin and cefazolin, have now surpassed them in multiple national registries. This timeline categorizes triggers by symptom onset. In the first 30 minutes following induction, intravenous antibiotics and neuromuscular blocking agents are the primary targets. Reactions presenting after 30 minutes implicate hidden allergens, chlorhexidine preparations, patent blue V dye, or reversal agents like Sogamidex. Sogamidex and chlorhexidine pose a distinct danger because of this delayed presentation. The hemodynamic collapse often occurs precisely as the patient is being transferred to the recovery room. Mapping the exact temporal relationship between the administration of a drug and the onset of hemodynamic instability is the critical first step in isolating the unseen trigger. Diagnosing anaphylaxis is inherently a clinical exercise, but the operating room presents a unique diagnostic blind spot. The patient is draped, anesthetized, and unconscious. The classic hallmarks of an allergic reaction, nausea, a sudden sense of impending doom, pruritus, and shortness of breath, cannot be communicated. Many clinicians wait to observe cutaneous signs, like generalized erythema or hives, before declaring an anaphylactic emergency. In the operating room, this reliance is dangerously unreliable. During a severe reaction, the resulting shock causes profound peripheral vasoconstriction. Blood is shunted away from the skin, physically preventing the formation of a visible rash. This grid displays the Ring and Mesmer grading scale. In life-threatening grade 3 and 4 reactions, cutaneous signs are often entirely absent. Instead, profound hypotension resisting standard vasopressors is the most reliable clinical indicator, present in nearly every severe case. While tachycardia is the expected compensatory response to this sudden pressure drop, the sudden onset of paradoxical bradycardia, or an absence of capnography, indicates that the patient is in imminent cardiac arrest. Waiting to visually confirm a rash under surgical drapes is a fatal cognitive bias. Acute unexplained hemodynamic collapse is the primary diagnostic threshold for perioperative anaphylaxis. Once anaphylaxis is suspected, the first protocolized action is immediate: halt the administration of all potential triggers. This means clamping concurrent antibiotic infusions, stopping colloidal volume expanders, and removing chlorhexidine-coated lines if possible. To reverse the resulting vasoplegia, epinephrine is the absolute non-negotiable cornerstone of acute pharmacological management. Because the patient already has established vascular access, the intravenous route is mandated in the OR. Intramuscular administration is suboptimal when rapid, titratable systemic delivery is required to prevent arrest. For a grade 3 reaction, the protocol requires immediate intravenous boluses of 50 to 200 micrograms of epinephrine, titrated to the patient's hemodynamic response. If the vasoplegia proves refractory to initial boluses, an epinephrine infusion at 0.05 to 0.1 micrograms per kilogram per minute must be established early. This line graph tracks intravascular volume, illustrating the massive fluid shift pathology. The rapid onset of capillary leak means up to 35% of volume translocates into the extravascular space within 10 minutes. To counteract this severe hypovolemia, aggressive crystalloid fluid resuscitation is required immediately. Mechanically, the patient must be placed in the Trendelenburg position or utilize leg-raising maneuvers to optimize venous return to the heart. Conversely, suddenly placing a patient in anaphylactic shock into an upright position can drain the central venous system, resulting in empty ventricle syndrome and sudden cardiac death. Survival depends entirely on the simultaneous aggressive mechanical and pharmacological reversal of this profound shock. In a subset of cases, the patient will remain profoundly hypertensive despite massive fluid resuscitation and escalating doses of epinephrine. When epinephrine fails, vasopressin becomes the critical secondary agent. If the patient is on chronic beta-blocker therapy, their receptors may physically resist catecholamines. In these specific cases, glucagon is administered to increase cardiac contractility independently of the beta-adrenergic system. Crucially, corticosteroids and antihistamines have absolutely no role in the acute resuscitation of cardiovascular collapse. Primary stabilization relies solely on restoring mechanical tissue perfusion. Modulating the slower immune response with steroids is strictly a secondary priority, to address only after the patient's hemodynamics are secure. Once the patient is stabilized, the acute crisis ends, but the clinical protocol continues. Mandatory transfer to an intensive care unit is required for at least 24 hours of observation. This critical care period is necessary to monitor for biphasic allergic reactions, where symptoms return hours after initial resolution, and to manage secondary end-organ ischemia caused by the severe hypotensive episode. This Cartesian graph tracks serum tryptase levels over time. Obtaining these blood samples provides the necessary biochemical proof that mast cell degranulation occurred. The protocol requires a strict 3-sample sequence. Sample 1 is the acute draw. It must be taken as soon as practical, ideally within the first 30 minutes, to capture the initial wave of mediator release. Sample 2 targets the peak phase. It is drawn 1 to 2 hours after the onset of symptoms to capture the absolute highest concentration of tryptase in the serum. Sample 3 is the baseline. It is drawn more than 24 hours after symptom resolution to establish the patient's normal physiological tryptase level for mathematical comparison. Demonstrating this dynamic rise and fall of tryptase is the only objective way to definitively separate an anaphylactic event from the myriad other causes of perioperative shock. Every patient who survives a grade 3 to 5 reaction must be formally referred to a specialist perioperative allergy clinic. The case is not closed until the trigger is identified. This investigation relies on specific in vitro IgE blood assays and highly controlled skin prick testing performed by allergy specialists. The rule governing this testing is absolute. Every single pharmaceutical agent administered to the patient within the 60 minutes prior to their hemodynamic collapse must be tested. This panel must explicitly include hidden environmental exposures present in the OR, such as latex products and chlorhexidine disinfectants. The required output of this investigation is absolute documentation of the verified culprit agent in the patient's medical record, accompanied by a curated, safe anesthetic plan for any future procedures. Completing this rigorous diagnostic process is the final, essential duty of the perioperative team. It ensures the patient's subsequent surgery does not become their last.